Welcome to NU 623 Adult Healthcare Unit 3 Presentation 2. This will cover upper respiratory infection and pneumonia. Your typical presentation with an upper respiratory illness is going to have some generalized findings such as cough, rhinorrhea, pharyngitis, headache, malaise, myalgias and arthralgias, and irritated mucous membranes. If in flu, you're going to see a high fever with a sudden onset, body aches, rigors, and shaking, and the patient might look acutely ill. In a regular respiratory infection, you're just going to see minimal findings on exam, and you might see some cervical lymphadenopathy, but you'll typically hear clear breath sounds. Your diagnosis for most upper respiratory infections, such as allergies, common cold, and laryngitis, are going to be largely based on the presentation. Your patient might not need any tests at all. If you have a more severe presentation, you're going to want to rule out flu A and B. All you need is the symptoms, the physical exam, and the test to diagnose that. Sometimes the test is negative, but all the symptoms are present, and you have to use your clinical judgment whether to treat them. If you're concerned about pneumonia, you can do a CBC, which would be looking for leukocytosis or lymphocytosis, and a chest x-ray. Consider also tests for strep, mono, mycoplasma as well to rule out these other differentials based on presentation. They're going to be covered in later presentations. Your treatment plan is going to be largely symptomatic: rest, hydration, nasal or oral decongestants, nasal corticosteroids, Tylenol or ibuprofen. These are all mostly going to be over-the-counter medications. Antibiotics are not used for flu or common colds, but you do want to prevent secondary infections. If you do have a confirmed flu, you have the option of treating with oseltamivir, but it needs to be within 48 hours of symptom onset. You're also going to want to educate your patient on transmission, expected course of recovery, medications, any red flag symptoms, and when to return to the clinic. Your patients should see a gradual improvement over 3 to 5 days. If not, they need to be seen again because of the instance of a secondary bacterial infection that would require follow-up and treatment. Symptoms should not last longer than 10 days, and the fever should not last longer than 4 days. So if these occur, or if they develop a productive cough, you're going to want to tell them to come back to the clinic to be seen. A referral is generally not needed for upper respiratory infections, but those who have comorbid disorders that increase their chance of mortality, like COPD or asthma or immune deficiency syndromes, they may need to be hospitalized. If they have respiratory distress, if they have a development of a secondary bacterial pneumonia that requires IV antibiotics, that would also call for hospitalization. Your typical pneumonias are going to predominantly be caused by strep pneumoniae. Patients are going to present acutely ill with a purulent or rust-colored cough, sudden onset of fever, increased heart rate or respiratory rate. They're going to be fairly fatigued. They may even complain of pleuritic type of chest pain. For lung sounds, they could either be diminished or with crackles. You might even hear a pleural friction rub. If there's severe consolidation, when you percuss them, you will notice consolidation. When you do the test for egophony, the E changes to A, the bronchophony, where your voice sounds are louder and clearer than normal, and whispered pectroliloquy, where your whispered sounds are louder and clearer than normal. You may also see tactile fremitus. Please be sure you look at box 30.2 on page 376 so that you could see the different organisms that cause pneumonia by the typical and atypical classes. Atypical pneumonias, your patient is usually going to present not as ill as a typical pneumonia. Mycoplasma pneumonia is the leading cause of these pneumonias. You're typically going to see this in patients younger than 35 years old, and it's going to be a more gradual onset. They'll have a cough, but it won't necessarily be productive. Fever could still have sudden onset and chills. They'll be tired. They may have a sore throat. They may complain of a pounding headache. Coryza will be noted, which is the inflammation of the mucous membranes and nasal discharge. For lung sounds, you'll probably hear crackles in the early stages, and then crackles, wheezes in the late stages, and there may be dullness on percussion. Sometimes, a very small amount of time, they can have a maculopapular rash. In viral pneumonia, it's going to present very similar, but it's going to be milder than a bacterial pneumonia. The cough is usually going to be a mucopurulent sputum. I want to make sure that you do look at the common organisms causing pneumonia by the typical and atypical classes in your text as well. A chest x-ray is considered the gold standard for diagnosis of pneumonia. You're going to see dense shadows in the lobes on a bacterial pneumonia. In a viral or atypical pneumonia, you might see diffuse infiltrates. The chest x-ray can also help you identify pleural effusions and any cavities or area of necrotic waste caused by anaerobes or fungi. The test can also be normal in early disease or for those who can't mount a good inflammatory process. Pulse oximetry is also going to be important so you can see their oxygen saturation. The CBC with differential, your white count, if it's greater than 15,000, can suggest a bacterial infection. Gram stain and sputum specimens can be done. I want you to look at box 30.1 on page 381. This is an optional test for outpatients, so I want you to understand the pros and cons of this test. I've personally not seen this used in the outpatient setting. The responsible microbe is only identified in about 50% of patients, and that's probably one of the reasons why we usually just treat empirically. Influenza testing is also something that should be done, and any additional testing may be done if they're hospitalized. You need to refer to your text for that. You can do the severity of illness pneumonia index, and this can be used to identify which adult patients with community-acquired pneumonia may be candidates for outpatient treatment. On your differential diagnosis, make sure you review these disorders in your text to help you understand the differential workups. Outpatient antibiotic choices are based on the presence or absence of comorbidities and whether there has been any treatment with antibiotics in the last 3 months. Please make sure you look at the chart on page 383 so you can understand the different choices and when they're used. Symptomatic treatment is also employed. You're going to have them increase their fluids. They're going to rest during the acute phase. They're likely going to be struggling for some air. Analgesia for pain. And you're going to do a lot of education with them on the disease, the treatment, the expected course of recovery, what red flag symptoms they need to be looking for, and when to seek additional care. If it turns out to be a viral pneumonia, you may want to consider testing and treating for flu with oseltamivir, as long as they're in the recommended time frame for starting the dose. Follow-up time frames really depend on the severity of the illness and the patient's general state of health. Usually you're going to follow up within 24 to 72 hours as the condition warrants. You want to consider a follow-up chest x-ray about 4 to 6 weeks after treatment is completed in those who are smokers and in patients older than 40 years old. Referral may be to the hospital if they appear toxic, they have shortness of breath that's severe, their symptoms are worsening despite treatment, or patients with suspected virulent strains of pneumonia, such as MRSA. Patients who prompt concerns about the level of observation and or medication adherence as an outpatient should also be admitted. You might want to refer to pulmonology for those with chronic pulmonary comorbid conditions. They really should be being followed by one of these specialists. Please refer to your text for additional information. This slide presentation has only given you some of the highlights.